I'm Richard Yan, inventor of the technology and founder and CEO of Fiplate. I would like to talk about tissue regeneration after radiological and acute trauma. I devote a big portion of my life to this problem because I have seen too many times how bad things can happen when the necessary technology is not in place to take care of the problem. When I was an intern, they brought in a trauma case. I saw this teenager girl. She did not wear her seatbelt, was thrown off the car, hit a tree, truncated her liver. The surgical team tried very hard to stop bleeding. It's the liver. You could not do anything, so they packed the abdomen. We give transfusion, continue to bleed, surgery again, give more transfusion, and after a whole month of ICU, she died. This technology was developed with my company with the mission of doing two things: to help develop effective technology for the mitigation of radiation harm. Now, radiation harm is not only happening to the astronauts, but it happens to a large segment of patients, particularly those who need radiation therapy after cancer surgery. The second thing is that we also want to promote healing in multiple tissues after trauma. Trauma happens on Earth all the time, but at least, no matter where you are, you get some medical help. With the astronauts or the colonists in another planet, when trauma happens, I doubt if there's a surgical team to help you. There's certainly no hospital setting yet that we can think of. So if there is a compound that you can do or medication you can develop that can do both, that would be wonderful. Especially given the known fact that in any tissue that has been irradiated, healing process is delayed and very difficult because of complicated biological events that have been disrupted by radiation. To do this, the means of achieving this is to do two things. Is to decrease the internal bleeding caused by radiation, which is a major component of radiation harm. The radiation causes damage to the endothelium, which is the lining of the blood vessel, and when that leaks, you will have accumulation of blood into the tissues, the muscles, the nerve, and so on. Most people did not notice that because it's not external, but they accumulate there and cause tremendous amount of harm because blood by itself is very, very oxidative. It disrupts the normal biochemistry of the body. Trauma from outside, external bleeding as well as internal, it could be a big problem. So we would like to decrease that. And the second means we find out that very surprisingly, the product that I have developed is able to not only stop bleeding, but it mobilizes stem cells, precursor cells, which will accelerate the wound healing in multiple tissues. Now, one of the key events of controlling the most important event in control of bleeding is that the platelets will be activated at the wound site. We all have platelets circulating in us, never cause any problem, never have any random clots until it comes to a wound site. It's the wound site that provides the signal to tell the platelets to be activated. It becomes sticky and basically attach on the wound, contract and seal the wound if there are enough platelets to do the work in time. We noticed at that time, when I first worked on this project, was that the major event of this activation of the platelet is the coating of fibrinogen onto the platelets. So I was thinking, well, if the patient doesn't have enough platelets, and on the hypothesis the body really doesn't care what kind of particle it is, as long as there's a particle to seal the thing, why don't I just make a albumin sphere? Albumin is a very natural molecule in your body. We have tons of it. We can buy it off the shelf. Polymerize it into a sphere so that the body will recognize it as a albumin, big albumin, but not rejecting it, no antibody reaction. Coat it with fibrinogen and see what will happen. Well, indeed, if you look at the top panel, it's just these spheres. But if you put it together with the suspension of platelets, you find that it doesn't do anything because it's just albumin together with platelets. However, if you add a platelet activating agent, it will form these co-aggregates. We have actually gone into the trouble of looking at a clot inside an animal and take out the clot and look at it under electron microscopy and find that, yes, these are trapped within the clot of a live animal. Of course, by the time we look at it, it's no longer live anymore. So it's called the fibrinogen-coated albumin spheres, FAS, and it's completely inert in vitro and in vivo, except when it's trapped passively by the activated platelets to form co-aggregates. So all the signals is on the wall at the wound site, and we don't even need to see or know where it is. So it's not a topical application from the skin from outside, but anywhere you have a damage on the inside, it will find itself and plug up that hole. But surprisingly, it has a second effect, and we find out that it can activate precursor or progenitor cells with the appropriate receptors. Now, the questions can be asked, well, if Dr. Yan, you are only making a product that mimics the function of platelets, well, why don't you give more platelets? The short answer is we can do things that platelets cannot do. And first of all, if the patient is not low in platelet counts, we find out that we can even use it on patients that have normal platelet counts. Medically, you are not supposed to transfuse platelets. You transfuse only when they have low platelet counts. My product, FAS, can actually, our job is not only to reduce the use of platelets. Our ambition is to replace the entire platelet transfusion market, which at the present time is $5 billion a year worldwide. Why would you be so ambitious to say that? Well, because number one, if you want to use platelets, you need healthy donors, and our product does not require that. That's so often in the operating room, when I need the platelets, when the surgeon cut the wrong vessel, let's point out, you have to call the blood bank. It's not available, okay? And by the time it arrives, the patient doesn't need it anymore, or the patient is not there to use it anymore. Even now, 12% to 14% of the collected platelets are wasted. Shelf life is only 5 days. FAS has a shelf life of over a year in room temperature, does not require any shaking, does not require any special form of storage, can tolerate over 40 degrees. A soldier basically can put it in a pack and go to the battleground where there's no infrastructure to support for major wounds. You cannot guarantee sterility in the platelet. In fact, after 5 days, there's plenty of bacteria in the bag. We never tell our patients that way because that's the only product you have, but you are getting that too. My product is completely sterile. Antibody formation against the platelets, yes, that's a big problem with platelet transfusion. Up to 30% of the patient will have that. Once you have that, it's resistant to platelet transfusion, and the patient will continue to bleed. My product does not cause that problem. Can this be mass-produced? Yes, but not in platelets. Some competitors trying to cultivate stem cells to grow more platelets. They really have a problem growing enough platelets, and they have all the problem with platelets to start with anyway. So I don't worry about that particular attempt. But the other thing is very, very important is that FAS can mobilize precursor cells. Platelets are not known to do that at all. So we are marching into the regenerative biology field. Think about Alzheimer's disease, think about severe spinal cord injuries. We are moving into that. So we definitely will replace the platelet transfusion market, or at least aim to do that. Some data to show how it works. FAS decreases blood loss by 55% in a non-thrombocytopenic patient. It's very hard to find low platelet animal models because to do that, it requires a lot of work. So I just said, let's simplify it. Let's find a normal platelet, which is applicable to most surgical situations, because in human patients, if you're low in platelet, you're not going to do the surgery. They cut the liver, and we find that there's a 55% savings in less blood loss. The major thing is not blood loss. The major thing is reducing surgical time. So often, I can tell you, an anesthesiologist looking over the curtain, half the time the surgeon is trying to clear the field so that he can see where to put the suture. Blood's coming out, dab it, clean it, wait for it. It's not just the blood loss, but the surgical time. Think, if every surgery can be finished 10% faster, the hospital CEO would be demanding that surgeons will use this product if possible, okay? And insurance is a major issue there too. When you can do more, that would be much better for the whole economy of the system. Another situation would be radiation therapy. And this is a lady that has the breast cancer, and after surgery, find out that within a few months. It doesn't happen right away. It takes some time later on. The skin came off. Very often, it's misdiagnosed. People thought it's a cancer coming back. And it's very painful. Well, you're supposed to be experiencing pain. So it's misdiagnosed until very much later on, it becomes ulcerated like this, require plastic surgery, very, very expensive surgery. The whole flap needs to be transferred with the blood vessels and muscle to patch the particular area. Well, with the application of the fibrinogen-coated albumin spheres, it mobilizes the stem cells and accelerates the healing without any surgical intervention. Now, when we first did this experiment where we have the rats and irradiate with 25 gray of radiation to the hind leg, for first 14 days, we saw nothing. We were tempted to ask the technician, did you do the experiment? Did you irradiate the rats at all? Yes. And then when it came out, the treated ones were worse than the control ones. And everybody is scratching their head. Did you mix up the group? No. What happened is this. The skin normally takes about 28 days for the basal layer, the stem cells, to grow up to the surface. By the time it comes to the surface, dead cells, okay? And so what happened is with this one, with the FAS given after the radiation is gone already. The effect will continue, but the radiation is gone, and so you mobilize the stem cells afterwards. The stem cell will quickly push the layer out, and so the first time you see it, it appears right away, day 14 instead of day 28, but then the ulcer gets healed. It gets smaller and smaller. Well, you would think that if you give the product before radiation, it's pre-treating it, it should be better, which is what most other people do. But first of all, you cannot predict the time of exposure. And in this case, yes, you do, but when you give it, it's less because after you give it, the stem cells are mobilized, but then you hit it with the radiation, and the radiation kills the stem cells. So you're decreasing the therapy that you're trying to give. But then at least it's better. It peaks at 28 days and then come down. The control ones, given saline, continue to fester, it gets bigger. It really requires plastic surgery. We're not doing that on the rat. And so it really major difference. Start healing on day 14 versus no healing up to day 51. The third model is testing whether it can improve survival. This is the first synthetic agent that has been shown to improve survival. Why do I say that? Because stopping bleeding or reducing bleeding is one thing. Whether reducing bleeding will lead to survival is a completely different story. So the NIH group demands that, DOD demands that, so we did the experiment. We asked the university to do that. And so they irradiated the animal, so there's 95% dying with only 5% surviving. Normally, if there's a drug that you can improve 5% survival to 10% survival, it would be wonderful because you're doubling survival. We put it in and find that it improved from 5% to 60%. It's a 1,200% improvement after a lethal dose of whole body irradiation. So the product works by decreasing internal bleeding in the intestine and the brain. It's very good for astronauts if they need it. Nuclear industry, in case there's an accident, we can treat 10,000 patients at a time because you don't even need the IV. Push it in bolus and it will start working right away. National defense, definitely. So the team is myself. I have over 30 patents, single author. And I built the CGMP facility in Vegas using my own money. But now I need more help because we're moving into clinical trial. I cannot afford that. Victor Cho from Shenzhen has already signed up and will invest. So we have enough money for phase 1. We'll be starting this year. Dr. Mao is a professor of radiation medicine in Loma Linda University. She has already 2 flights and is an expert in the retinal changes and the brain changes. And I asked her, well, how can you study the brain? I mean, it's such a short exposure. And the thing is, the changes in the brain after a trip to the ISS, at least in animals, is obvious enough that you can study that. Not only that, it's highly likely to resemble the changes in the Alzheimer's diseases. So with the age-related long-term human diseases, it's very difficult to study because you need such a long time to collect the data. And then to see if the therapy works, it's even more complicated. But if space flight can simulate that situation and provide correlates, it will provide insight into these long-term, very difficult to study problems. That's why we have planned on doing that. And Dr. Sodiak, I visited him at Boulder a month or so ago, and they trained the astronaut in doing the experiments. The astronaut she was up there doing experiment. The principal investigator was about 5 feet in front of me, making sure the experiment was done right. He is part of the team. So what have we done? What do we want to do? The progress since last year, December, is that I raised enough money to start phase 1 this year. And at this point, I really have to thank NASA iTech and NASA for awarding me the top 10 award last year because I put it in my office. And the investor came in, didn't care much about the biochemistry I was trying to explain. Saw the plaque, liked the plaque, took a lot of pictures, sent it to his boss, and we got the money. So I'm hoping to get a bigger plaque this time. Okay, so what do we intend to do? With the money, we intend to do phase 2 and phase 3, more money, and the profit will be $4,000 per bottle, per dose. And that's from the saving of earlier discharge for the patient who don't have the complications from platelets. So, and I thank you very much for your attention, and we can have more discussion following. Yes.
Please.
Yes, it's an intravenous injection, and the dose is 1 ml per kilo. So if you're a 100-kilo soldier, 220 pounds, all you need is 100 cc. I should have brought the bottle with me, but I didn't. It's just a small one, and you just inject it. The nice thing is you do not even need an intravenous line. With platelets, you cannot just get the bag and squeeze it in because you can break the platelets. And so you need a nurse to start an IV, hang that. In a hospital, it's not a problem. But in the battle condition or when you're in a rudimentary situation with no infrastructure support, platelet, number one, you cannot get it. And if there's a virus infection or something going on, the FDA will not allow platelets to be collected anyway, even if they're volunteers. But my product, all a soldier needs to do is tie a tourniquet around somebody to find a vein. If you don't have a tourniquet, just squeeze it. You'll find a vein, shoot it in. You can bolus it in.
In terms of its effectiveness against radiation, is it against all radiation or gamma, X-ray? What does it matter?
Right now, we have only done gamma radiation. We have not done cosmic ray, and this is what the space flight, we want to do that because it's far more high energy. And Loma Linda is uniquely situated to do that, but of course we'll use the national labs also. It's a function of money. We have everything set up. In fact, we not only will study the pathological changes to look at survival, we will study every tissue in the animal to find out, number one, which tissue is most impacted by long-term cosmic radiation, and which tissue and organ will be best protected with my product. So when we have that insight, it will be tremendous. And of course, I'm looking forward to long-term changes in the brain and other nervous system situations to apply it to the Earth situation where Alzheimer's is a major health problem and economic problem.
Yes, have you detected side effects?
No.
No.
We try very hard. First of all, the first thing that people worry is that will they form random clots? And in the animal, there's a very good testing called the Wheeler's method, where you inject the material here. If it's slightly thrombogenic, forming clots, the way to detect it is you open this side also internal jugular, you actually ligate the thing and wait for 10 minutes. And if the thing would cause any clot because the blood does not flow and will form clots, you will detect that. We have tried, and no matter what you do, it doesn't. The reason is very simple. You have plenty of platelets. You normally do not form clots unless there's a wound. And you may not even know internally you have a wound, but it will find itself and form it there. This particle is designed so that, number one, the albumin sphere are very benign. It's porous. the body look at it as is, oh, the albumin is not doing anything against it. And then you have fibrinogen. You have plenty of fibrinogen, but you don't form clots. So the body doesn't detect that there's a thing there, but it's a mass, so that it will be there to clot it up. So we have done, actually, we have completed clinical trial in China. Phase 1, no problem. Phase 2, phase 3, over 600 patients. They all do well and have no complication. We know that. And in the Duke University, they have looked at every tissue afterwards. They dissect every known organ, the brain, the kidney, everything. No clot. And then all the biochemical parameters, all the clotting times, all the prothrombin time, everything normal, no problem. No DIC, no nothing, because of the design. It doesn't carry the message in the sphere. The sphere is just passing by gently, and because of the small size, it's very close to the wall. And so when the wound happens on the wall, all the subsequent reaction to form a clot from trapping to the solid clot is on the wall. So you don't have a problem. You solve the problem without causing any problem. Yes?
Please excuse my ignorance, in this field, but what about long-term, mutation? I mean, is that covered by the studies that you've done? How long are those? Like, if this is in your body for 20 or 30 years?
Oh, no. This is about, it stays about 5 to 6 days. Then it will be metabolized by the liver and cut in small pieces and excreted in the fecal material as well as the urine. So it's degraded, but still it has a effective life of 5 to 10 days. It's not in years. It's a biological material. It doesn't cause any cancer. It doesn't have any biological effect. This is very weird to make this statement, that I might have made the first drug that doesn't do anything. It's a test. You study whatever you want. You put it in your body, it doesn't do anything. Now, the only thing is that if there's a wound, then it got trapped. So it's not its fault that it got trapped. It's all the place activating. It's a brother, come here, sit here. That's it. Yes.
I know you talked about it briefly as far as in the setting of radiation, but for surgery, is there a prophylactic use for your product?
Absolutely.
Okay.
The reason I have not talked a lot about it because it's only 2 years ago that we dared to move from the low-plated animal model to the full-plated model. Because in any test that you can you want to evaluate a product on, nobody wants to test it on a normal platelet because your bleeding is normal. Everything is normal. How can you improve it? There's no expectation that you will improve it. The only reason I'm moving to that area is because survival is too difficult to do. You irradiate an animal, and then you try to get it to 95% lethality and 5% survival. A little bit more, they all die. You have nothing to work with. A little bit less, they all survive. There's nothing to test on. So it drives everybody nuts. So it drives me nuts because I have to wait. So I say, forget it. Let's do a radiation on the leg. And all you need is 5 rats. I mean, you don't need 100 of them to test. And the result is so spectacular. For a year, nobody can explain it. How do you explain that the controls have a smaller ulcer and your treated one get a bigger ulcer? What went wrong? So finally it dawned on me, oh my God, it's right. We are doing the right thing, and we're mobilizing the stem cells. And so to answer your question, that's what we have done. And so right now, in the surgical situation, bleeding from the knee, bleeding from a lot of hip surgery, and it's a major problem because after also orthopedic surgery, the bone is hollow. You cannot put a suture around it. So they packed it, and so we can easily demonstrate that if the anesthesiologist or surgeon would give it 1 hour before surgery, you can save a lot of blood. This has saving not only on platelet. We're not only taking over the platelet field. You have much fewer red cell transfusion because if you're not losing it, why do you need to replace it? So we are very bold in this, but we're not in the red cell. We're not making artificial red cells. Okay, I've done that already. It's too expensive, not worth the market. So this is good enough.
Thank you, Dr. Yin.
Thank you.
Thank you much.
Okay.